Yeah, in this clinical session, you will be asked to assess this baby, and you are specifically asked to assess the lower limb neurological examination.
Okay.
Okay.
Yes.
So, if you want, we can start the timer for preparation.
Yeah, prepare. Yeah. Let's do it.
Sorry, I will just modify the task a bit.
Yeah.
Because in this situation where you have, you have a small baby, so you can do a complete neurodevelopmental assessment, neurological examination of the baby from top to bottom.
Okay.
Okay.
Okay. Yes.
But yeah, if you've got any questions, if you're not comfortable, just let me know.
Okay.
Okay. Yeah.
Okay. Let's start.
Yeah. So start.
Yeah. Hello, my name is Ubaid, and I am one of the pediatric registrars in the clinic. How may I call you?
Yeah, you can call me Chloe.
Chloe, and you are mother to?
Little Amy.
Little Amy. Well, Chloe, very nice to meet you. I'm here to examine little Amy here. Is that right? Is that okay?
Yeah, that's fine.
Okay. I would like to assess the surroundings, and I would like to observe Amy from head to toe and see if she has got any medical instrumentation or anything with her. And then
so as you can see, the objects, the things which are present.
Yeah. So
in the image, yeah.
Okay, I can see that there is a nasogastric NG tube intact, and I can see that she can put her weight on her forearms, and she can raise she can raise her head above her torso. Now, mommy, if you could assist me, if you could put her on her back, is that okay with you?
Yeah, that's fine. So when the baby, when the child is turned towards the back, you can see in the lower sacral spinal area a scar which is present. A dressing, a gauze piece dressing that's present. And yeah, what would you like to do after that?
Okay, I would like now the patient is in supine position, and I would like to see what is the position of her both lower limbs. Is it a frog-like posture? What is the tone? Are they flexed or not? And then depending on that, I would proceed further.
Yeah, so the when you look at the legs, it is, as you can see, it's in a more of a frog-like position, and she's not moving the legs much, and there are no scars or any surgical marks present there.
Okay.
And it's hanging when she sits down on mummy's lap. It's hanging by by the lap, and when she is lying down, it is touching to the ground.
Okay, mommy, is it okay if I expose both the legs and thighs?
Yeah, that's fine.
Okay, I would try to look for the tone and for any fasciculations there. And then I would like to assess deep tendon reflexes and planters, and then I would like to assess the back of Emmy and see any scar marks or any deformity in the lumbar or cervical spinal cord or thoracic spinal cord. Look for the shape, position of the whole spine.
So when you examine the complete back, the whole spine, you can see there's a lateral severe scoliosis present. And just coming back to the lower limb examination, which you just mentioned, you would check for. Can you repeat what would you be checking for?
I would look for tone, fasciculations, deep tendon reflexes, and planters, and see if when I'm touching, if she feels anything at all, sensation.
Okay. So she doesn't seem to be appreciating your touch or responding to the sensation. How will you be assessing the tone?
I will look for tone on every joint and see if there is any stiffness. And I would like to flex both the legs at knees and see if they are in their position or if they fall on the sides.
Yeah. So upon doing that maneuver, the legs, after flexing the knee, the legs usually fall back on the bed, and on assessing the tone with the movement of the with limb, you can appreciate that it's hypotonic, it's floppy.
Okay, so now I would like to proceed further and check the abdominal reflexes, and then check the. I could already see that there is some tone in the upper limbs, and I can see that there is a scar. There is. I would like to open the. Remove the dressing and see what sort of scar is there. I could already see that there is scoliosis. I would like to assess.
When you've removed the dressing, you can see a pink, healthy wound tissue with no discharges, and you can see the super exposed area of the nerve roots.
Okay. Now I would like to assess the face, see if the baby is fixating and following objects. I would like to look at the tongue and see the tongue for any fasciculations. And then
no fasciculations. Yeah.
Okay, and then pull to sit, and then put in a vertical in a horizontal position to see any anti-gravity movements, and then
so when you pull the child to sit, you can see there is a head control. When you hold the child horizontally for for vertical suspension, you can see that the child is able to. You have a good grip at the axilla. Child is able to move the upper limb, but the lower limb tends to be floppy. And what else you would like to do?
Okay. I would then like to take a head circumference and length and plot it on a centile chart. And see
so
if
both the head and this weight centiles plot on less than 0.4 centile on the chart.
Both the head circumference and length.
Yeah, the head circumference is between the second and first and second centile, and the weight and the length falls below 0.4 centile.
Okay. I would. Okay. I would like to assess if there is any scar marks on the front of the body or on the abdomen, and I would like to examine the abdomen as well for any organomegaly.
So abdomen, I mean, the child doesn't tolerate lying down in supine position because of the wound at the back. But as far as you can, so I'll stop. It's 6 minutes, is it the clinical, or is it 9 minutes?
6 minutes, I think.
Yeah. So yeah, the time is up. So just going back for abdomen examination, the child is not able to tolerate supine position because of the wound at the back. But when you try to do that when the child is sitting or on mom's lap, you don't feel the abdomen is soft and you cannot appreciate any organomegaly.
Okay, and there is no scar mark of any sort
No.
of or
No.
anything. That was my primary.
Yeah. So yeah, can you summarize?
So I examined 10 months old little Amy, who appears to be shorter and underweight for her age. And on plotting her on centile chart, her head circumference is between second and ninth centile, and her weight and length are below 0.4 centile. On examination, she appears to be hypotonic. Both her lower limbs appears to be hypotonic, and there are no deep tendon reflexes, and she is not responding to any kind of touch or painful sensation stimulus on both the lower limbs. There is a pink swelling at her lumbar spine, and she appears to have scoliosis, and other than that, yeah. So
and yeah. So what is your impression?
She is able to fix and follow on and on ventral suspension. She is. I could appreciate some anti-gravity movement in both the head, the head and the upper limbs, but no anti-gravity movement in the lower limbs. So this is my differential diagnosis here would be hypotonia of lower limbs secondary to some neural tube defects.
Mm-hmm.
And
what do you think could be the neural tube defect here?
Meningomyelocele.
Okay. And what are the, so in particular in relation to the patient present here, Amy, what do you think are the complications this condition the child has had with meningomyelocele?
The complications. Well, lower.
What are the associated conditions or the complications the child has developed looking at assessing on Amy today?
Well, she has failure to thrive, okay. And she has lower motor neuron type lesion of both the lower limbs due to the
yeah. And what do you think the image on her head is? Were you able to appreciate that?
Yes, that was what I.
Yeah. I would. At which exact point is this image? Is this thing?
Let me just share my screen again. Are you able to see? Yeah. So I'm talking about this one.
I cannot see your screen, Dr. Rice.
1 second. Saleh, are you able to see my screen? 1 second. Just do it again. Yeah, can you see now?
Yeah, we can see your screen.
Yeah, this one.
It is on the top.
Yeah, it is on the top. Okay, no problem.
No,
yeah,
I
so
couldn't.
No. What else do you think in terms of how would you manage this and what advice would you give to the family? And why do you think the wound at the back is still, the wound is still unrepaired? What makes you think that? And what, moving forward, what will be your management?
Well, I suppose, Dr. Reis, was there any scar mark of any sort of procedure?
On the back, there was a gauze dressing, and when you removed the gauze, you saw there was a pinkish wound, which without any discharge, and you could see exposed nerve roots. And there was one scar mark, as I mentioned, at the side of the wound. I'm not sure if I mentioned that or not, but there was one tiny scar mark, but most of the nerve roots were exposed. It was covered by thin film of a thin layer of a tissue, which is the meninges actually, and you could see the nerve root as a on direct visualization.
Okay, so
essentially the meningomyelocele, you can see the meningomyelocele exactly as it is, and it has not been repaired.
It has not been repaired.
Yeah, that is the impression of that wound. And what do you think that could be the reason? And what are the management you could think of? Anyways, the discussion, 3-minute discussion with the examiner has ended, but yeah, we'll continue. What were your thoughts?
Okay, so this is a meningomyelocele, and which is not repaired. Well, I suppose he needs to be seen by by pediatric neurosurgery,
Okay.
in liaison with pediatric neurology as well. And then I would like to liaise the patient's mom with occupational therapy and physiotherapy, so that they could assess, they could do an assessment of need, and then help the baby with some sort of hoisting if needed, and the physiotherapy could help with the hypotonia and look at the different muscular groups, just in order for having an eye on development of any sort of strictures or muscle wasting. I would also like to liaise my patient's mom with social worker, who help her with any sort of problems while they are helping little Emmy here. It would be greatly affecting their lives, so that we could provide some support. Other than that, I would also like to liaise them with community pediatrician who could follow up with regular growth and developmental monitoring. And
so in your clinic, what would you like to do at the moment? Anything specific?
At the moment, I would like to liaise with neurosurgery, with pediatric neurosurgery, and assess what plan they had in place for little Amy.
Okay, good. Anything in terms of any other intervention? Would you think of at that stage?
At this stage, I would like to take a detailed history, and find out the major concerns, and understanding of the patient, of the mom, and then act accordingly.
Okay, fine. So yeah, we will end this here, and I'll give the feedback. What do you, so on overall, what was your how was your view of the exam case scenario and how you performed?
I'm confident with my examination, and when I'm seeing a patient, I would be more structured. The opportunistic type of observation from head to toe. And then going with starting from any side, whether from head or from the lower limbs, I would be able to do that and examine the back and find out like, where exactly is the lesion and where exactly is the scoliosis. And then coming to summarizing, I could summarize. I think I summarized it. I wasn't able to find out what was on the head, the exact lesion, whether that was some sort of shunt or some sort of surgical, or I couldn't appreciate.
Yeah, no, that's fine.
Other than that, with regards to the management plan, I have to say that I was caught by surprise that what needs to be done here. And ideally, I would, with my management, I would be. I think I should start with saying that I need to take detailed and evaluate in detail the history of the patient and the needs assessment, and then proceed in a multidisciplinary approach, including myself as a pediatrician, and then contacting neurology and neurosurgery or looking for any correspondence from them and seeing what's their plan in terms of follow-up. And then depending on that, I would liaise with occupational therapy for assessment of need and physiotherapy.
Fine. So yeah, I'll just share it again. So in terms of, identifying and recognizing what's going on, I think that was all right, and you've done well in terms of that. But a few things I would like to give as a feedback in just to refine your examination and presentation. I know this is a bit challenging because we are doing it online, but in real exam scenario, you would be much more, you would be gathering much more information. You'd be a completely different way in terms of assessing the baby. But coming to the physical examination again, as I said, we are doing the same mistake again. That first we have to look around the patient, which you did exactly, and you were able to identify the NG tube. You were able to so it's and then I think you missed this bit, but this is called as the Omoaya reservoir. Okay.
Okay. So this is a.
Sorry.
This is shunt.
Yeah. This is not a shunt exactly. This is a reservoir.
Okay.
Omoaya reservoir. Okay. This is quite common in babies with hydrocephalus, or the one who have essentially it is to drain the CSF fluid as and when required.
Okay.
I just wanted to say, when you sew head to toe, right, when you have a neural tube defect, always look for VP shunt in the back of the ear. So this was, if you have seen an Omoya reservoir, then you would obviously look for that shunt.
No, like I seeing this, I think it is between the parietal bones, and that's what confused me. We always have seen that behind the ear, the reservoir.
No. So reservoir, it depends on neurosurgeons where they can put. But if you see a bulge, if you see a swelling like this, it can be most common site is here or this side. Yeah, it's unusual, but I didn't get the exact picture. But a classical bulge swelling like this should give away the what exactly it is. And if you see it in a real child, you should be able to appreciate this, and they expect you to because this is used for tapping. It is different from a VP shunt because the child does not have a VP shunt at this point in time, but they will need a VP shunt later on, because when the meningomyelin seal is repaired, there is a reactive hydrocephalus. Okay. So it will further increase CSF production. So they, as a definitive management, they will need a VP shunt. So if you could put this in your management, that will give you extra marks. It's you're not going to lose marks, or you're not going to be falling short in management. But if you do mention this, you will be getting extra marks. So just coming back to, examination structure, identifying all the medical equipments, and then looking at the patient. I think it's better to comment that the child is alert and active, the child looks well grown for age, or the child is lying and scoliosis. If you would ask me, I would have given you the cue that then and there itself. But in real exam scenario, when you will enter the exam room, you will appreciate these things. So it's better to put those things first. Like when you have looked around the patient, you have looked at the patient. So that will form a structure examination, and then you start with the proper examination of the neurological assessment. And it's better to start from head to toe. So I'm sorry I gave you initially the lower limb examination, so probably you started with the lower limb first. But it's better to start with the head to toe, where you have done the pull to sit, vertical suspension, horizontal suspension, and then you proceed down to the looking at the back, looking at the lower back. Then you look at the lower limbs, and then you would also like to look in the nappy area and check if there are um, any catheters or not, or you can check this with the mom as well, because these children also require intermittent catheterization. They have atonic bladder. If you have a diplegic lower limb, it's more than likely that the child is having atonic bladder. So there's very high chances that they will also have catheter, urinary catheters. So you may find it by the bedside of the patient as well. So be mindful of that. And and then with the structure of examination, and then you will have to so coming to missing the signs, there was obviously one sign missed, but most of the signs were picked up, like you picked up scoliosis by exposing the back. You picked up the meningomyelin seal by removing the again exposing the back and removing the dressing cover, and then you identified um, the lower limb being diplegic without any sensation, and it's being flaccid. And your assessment of neurology was all right. But again, in the neurological assessment, it's different. You are describing, you will check the tone, you will check this thing, but in real exam, you will be doing it in everything, all the assessments of these domains: tone, power, sensation, in stepwise manner. Okay, so tone contains inspection, palpation, and then examination. So inspection, you looked at the, like, it's frog-like position. Palpation you can do by rolling the limbs. So try to incorporate this in your examination technique, that you have got the child's limb lying flat on the bed or flat on mom's lap, and then you are rolling the limb like a log of wood, and then you will appreciate that it rolls easily. So and then you feel for the muscle bulk, you feel for the muscle, you are palpating for the muscle bulk, which will feel floppy. And then you proceed on with the active and passive movement. Try also to check for ankle clonus. It is not relevant in this case because it is completely opposite to that, but examiner should and also check for Babinski. So examiner should be able to examiner knows that what you're checking in a structured manner. So you have checked the tone, and then power, you will not so on observation, the child is not moving the limb. You have made attempt for active and passive movement. The child has not responded. It has literally been floppy. So the power is zero. You can say that power is zero. The tone is hypotonic, and the sensation wise, there was no sensation. And then you have to go for the level of sensation. You have to work your way up to from lower limb to up to the, like, umbilicus and to the abdomen. So once you start getting sensation, you can stop there. Okay, this should be in a quick manner, in a swift manner. If you know what you're doing, so you can proceed on with this examination. And so once you have gathered all these things, try to put this in work on your summarization skills as well. That I've seen a 10-month-old Amy who is alert and active, but she's undernourished, or she's poorly nourished, and she plots uh, her height and weight plots below the fourth centile, and her head circumference plots between second and ninth centiles, and the possible explanation could be hydrocephalus, and that's why she's having the Omoya reservoir. Okay, and then on assessment of her neurology, she has general she has hypotonia in her lower limb, and with hypotonia with absent power and absent Babinski. And she has got, in terms of her upper limb, she's got best observed power is more than 3/5, and because she's actively moving her hands, and she's got sensations intact on the upper half of her body. And on the examination of her back, there's a unrepaired meningomyelocele, and she's also got severe scoliosis. So my impression is, so you have listed all your points. Underweight, she's got NG tube in situ, underweight, and then your list in neurological findings. And then, so my impression is that it's an unrepaired meningomyelocele with hypotonia of the lower limbs. And then the examiner may ask you, why do you think it's unrepaired? The most common reason is the child is not medically fit. Child has not gained enough weight. They cannot tolerate anesthesia sometimes, so they don't take them for operation, especially with severe scoliosis. So these are one of the reasons. But this is, I would say, these are extra marks questions. But the common questions is, what are the complications? The complications will be a neurogenic bladder, a hypertonic bladder, hydrocephalus. Like in her case, it was a hydrocephalus. She had the MOI reservoir, and um, uh, the general nutrition aspect, where the child's neurodevelopment is lacking, and that is resulting in her disability and immobility. Okay, so these are the complications. And what would you do in terms of managing this patient here in your clinic? Will be to get a nutritional assessment first. If the child is on, how has the child gained weight, and what are the FBCs, what is the hemoglobin, what are the vitamin bone profile levels. You will do that. You would also organize a cranial ultrasound scan, because they tend to accumulate CSF. They need tapping quite frequently, tapping of the CSF, which can be like every alternate day, or every day, or every week, depends on how their choroid plexus is functioning. So you would like to arrange ultrasound, you would like to involve the dietitians, you would like to then check with the neurosurgeons, as you have rightly said, and then involve the occupational physiotherapist, social disability allowance, and all those things, the extra bits. The specific things as a pediatrician you would like to do is nutritional assessment, cranial ultrasound, and the and if you have identified there is any discharge from the wound, because they are very prone for infection in the open wound, it's not bad. Yeah, you would like to take a wound swab as well.
Okay.
And so this also brings into one other topic of video station, where they are tapping a MOI reservoir. I was trying to get that video, I couldn't get to try to find it on YouTube, but that is a potential video station examination. Because it has come up, I just wanted to say that it can be there in your examination as well.
I think Dr. Ubaid has done quite okay, but
yeah,
what
it was a difficult, it's a difficult station, and it's more of a verbal as we are speaking, but these are the things.
Yeah, but what Dr. Raiz is trying to tell you is, if you cover this much, right, you are definite to get full marks. Okay, and if you get full marks, it's your job's easier, right? So another complication would be seizures, and what do you say, hearing problems in such children, neuropathic bladder, nutrition, as Dr. Rai said. Yeah. But I feel, when Ubaid is doing this is not a video, like when you're in real station, you will be able to palpate that Omaya reservoir, and you can you could then say it is a reservoir.
Yeah,
it's very hard.
Could, and then I think the amount of videos that I have seen, they always put like, I would like to plot on head circumference and growth chart. They just say that in when they are narrating their findings. But I brought it earlier because I was looking for hydrocephalus. That's why I brought hydrocephalus, and I was looking for hydrocephalus, and Raiz Bhai told me about the undernutrition, And I think that was the key point where I missed the whole station for undernutrition. I think undernutrition as part of meningomyelin. So I should have added the management of undernutrition as well.
Yeah, I mean it's not a hard and fast rule where you bring the plotting of the height and weight. It can be at any point, but the reason we emphasize to put it uh, at the beginning is so that you do not forget. Because when you keep it for each station, for each examination at different places, you tend to forget, you tend to miss out, and you may not realize that you have missed it out. So but if you and it is something that is so mandatory and so common in all the clinical station, you will have to do a plotting. So try to put that in the first and get done with it in the first instance. So that's the only reason. Otherwise it doesn't actually matter in the structure of examination. The structure of examination in the neurological here will be proper inspection from head to toe, taking out all the signs, and then assessment of neurology will be for any dysmorphism, sorry, any hydrocephalus, head circumference which you have done, and then the assessment of the tone, full to set, vertical and horizontal suspension, and then looking at the tone of the upper limb if the child is able to move the upper limb spontaneously, looking at the back, and then coming down to the lower limb. Lower limb again, tone, power, reflexes. Tone, power, reflexes, and then reflexes is again deep tendon and superficial, and then sensation. The last part is sensation. I don't think you will be getting enough time to do everything. They may give you isolated just do the lower limb assessment, in which case you will do the tone, power, reflexes, and an examination of the back. So that will be it.
Okay.
Where the exams may not be this tough, but for your bad luck, this can be kept in one of the clinical stations. Do you understand?
So, I'm very quick with examination. And now that I know that if you feel that the child is undernourished, if it appears to you, and you could very easily pick it on just looking from head to toe. So just don't miss out on these, because with regards to even the cardiac surgeries, they would need to optimize the child for a surgery, and now I know that we need to optimize this child for surgery. I think that was the crux of the whole thing. Yeah. Hello.
Yeah, sorry. Yeah, that is. I mean, in
Yeah, that is exactly
this particular
true.
examination, the undernutrition was quite a major thing, because of that the child couldn't get the surgery, couldn't get the and obviously the severe scoliosis as well, because they are not able to tolerate the anesthesia, prolonged anesthesia for this major procedure. So, and in any clinical examination, they expect you to address the nutrition aspect, address the plotting of the height and weight centiles.
Okay. And when we are doing it, we will be plotting it on the centile charts ourselves.
No. It will be
No,
already
there is a
plotted.
separate station for growth chart plotting.
Okay. Okay.
That is usually
In this scenario, it will be already plotted.
yeah.
Okay. Okay. Because plotting is in itself would take at least
Yeah,
half.
yeah. And it is that in itself is a major assessment of a candidate in MRCPCH. So there is a different station dedicated to where you have, as a part of assessment, you have to do the plotting on the right chart. They will offer you many charts. You have to pick the right chart and offer. It could be in obesity, it could be in a short stature, tall stature, or a failure to thrive. These four clinical scenarios, if you get this station, um, you are expected to plot the height and weight in a relevant chart. If you have a Down syndrome child and if you plot in a normal chart, you will lose marks. If you have a girl,
Three
you
types of
plot in
chart:
boys
Down
chart.
syndrome chart, 23 to 40 weeks, and then corrected age chart, and then the normal chart. Yeah.
Yeah, and then you people make silly mistakes, like if it's a girl child and they plot in a boys chart, They lose marks.
So it's the blue is the boys and the red one is the pink one.
Yeah. So if you are used to plotting, you will not miss these things. So the point I'm trying to make is that there's a dedicated station, especially for this. But in neurological, you would not be doing that.
Okay, perfect. So anything else other than that? So this station, the whole station was about like they haven't done a surgery because the head circumference is not going in line with the weight and length. So the head is a 2 centile above the normal, yeah, above the weight
No.
centile.
It's not because of the hydrocephalus. They are not able to do the surgery because of the nutrition. The anesthetic drugs need to be.
Yeah. I was coming to that. Like
Yeah.
the child has got hydrocephalus
Yes.
and is malnutrit. There is malnourishment,
Yeah.
which should be optimized in liaison with nutritionist
Yeah.
and seeing how much calories is he taking. So okay, that's
So these are common points, common reasons where if the surgery is delayed, it is mainly due to the weight issue. Other causes can be severe scoliosis that can impair ventilation, that can impair surgical intervention, and very rare cause will be the parents' wish of not moving forward with the surgery because of the risk benefit ratio. But that is a different topic of discussion. It's better we avoid going into that. But so it was undernutrition. The child was not um, fixed. Child did not have a repair. And your assessment as a candidate was to pick out the sign of a diplegic lower limb and list the complications and involve uh, which different professionals and your management in this child. That's it.
okay.
Yeah, you would also like to do a urine dipstick to check for urinary UTIs in these children.
Yes.
Yeah, so bloods, nutritional assessment, urine test, cranial ultrasound, and then involving the dietitians, neurosurgeons, pediatric neurologist, and an occupational and physiotherapist. They come last. Yeah. So this is the sequence of management.
Okay.
Okay.
Yes.
Dr. Rice, this has been an awesome case. Pretty good. Your entire neurology is discussed. Very good case.
Yeah, this is. I mean, the neurology is a very vast topic in itself. You will have a different spectrum of neurological assessment in a older child who is cooperative. In that examination sequence is completely different. You have to start with a gait assessment. Then you have to do with the power assessment by asking the child to move, checking the power in quadriceps, hamstrings, calf, and all those muscles. So that we will plan to do sometime else. But I
Dr.
think
Reis, in a similar child, if he was like 3 years old
yeah.
and he had this diplegia,
Hmm.
so if it was atonic like or hypotonic diplegia,
Yeah.
our differentials would be like an NTD, a possible NTD operated maybe,
Yeah.
and then Duchenne muscular dystrophy or hypotonic CP.
I would not say Duchenne muscular dystrophy in a diplegic scenario in a 3-year-old child because that's not the typical age of presentation, and they don't get diplegic at that age.
So they will be diplegic later.
Yeah, they will have a muscle wasting. It's more of a
first hypotonia, then hypertonia. First, always when there's a neural injury, there'll be hypotonia, and then slowly it'll progress into hypertonia, and there'll be scissoring of the legs. And when it's in this age, you won't find the scissoring. A little more as the child progresses, if you don't do physiotherapy, eventually it'll go into scissoring and diplegic, spastic
yeah.
diplegia.
Yeah, I would not list the DMD, Duchenne muscular dystrophy, earlier or in this diplegic instance if it was a 3 to 4 year old child. So can you just list me I would list SMA type 3.
SMA.
Yeah, type 3 first. Or so in terms of SMA, in terms of diplegia like this condition, and in terms of a cerebral palsy, in terms of DMD, can you list me where are the um, the lesion, the site of lesion, where is it affected? That will help you give you the differential diagnosis.
Spinal muscular atrophy.
Yeah.
It's the anterior horn.
Good. Yeah.
And then the second one?
CP.
CP is, it should be a hypotonic CP.
If it's a spastic CP. Spastic quadriplegic CP.
Spastic would be more likely in the cerebral cortex.
Yeah, so it's upper motor neuron. Yeah.
Upper neuron.
Yeah.
And
then in case of diplegia like this?
In case of diplegia like this, I think it's related to, I'm not sure.
It's lower motor neuron.
Spinal. Neural tube defect. Spinal.
Neural tube defect. Okay.
No, it's in going to the anatomical lesions. So you have upper motor neuron that comes and connects with the anterior horn cell. And then you have the spinal roots, which is the lower motor neuron, and then you have the neuromuscular junction, which is the DMDs, and then you have myasthenia
gravis and
and
GBS. So only myasthenia gravis is there.
Myasthenia gravis and Duchenne-Becker's spinal girdle, all the muscular dystrophies, they are muscular and the neuromuscular junction problems.
Okay.
Okay, so based on this, you would not like to list DMD in case of a diplegic or a completely, in this neural tube defects. DMD is a complete different scenario. It's a complete different spectrum of illness, and it's not how they present, and the age group doesn't match, the presentation doesn't match, the clinical signs doesn't match, except for absent deep tendon reflexes. That's it. But they will have power. They will have some power.
Okay. Yes.
And there are very few conditions which are involving the anterior horn cell. One is SMA. What is the other that we don't see now?
The other one, anterior horn motor, is I think
it is something that has been eradicated, but it's still present in our countries.
Polio.
Yeah, that's right.
Polio could present this. And then what about transverse myelitis?
Yeah, transverse myelitis, it's more of a lower motor neuron. It's not anterior horn cell. And transverse myelitis, it's in acute case, acute presentation.
Yeah.
You would not be getting that in your examination. It is more of a differential diagnosis of a GBS.
Okay. And what about Charcot-Marie tooth?
Charcot-Marie tooth is a peripheral nerve system, which is again lower motor neuron, and that is a common case in the UK. You will get, so read about that. It is in that station you would be expected to do a proper sensory assessment. So you will have to be very thorough with your sensory nerve roots and your which area, which dermatome supplies which nerve root. So be thorough with that. So it's a lower motor neuron, and
along
it's
with
more
sensory.
Along with sensory component. Yeah, peripheral neuropathy.
And then
along
with the pes cavus and or those.
Yeah.
And with scoliosis or something like that.
Yeah. So you will have the lower motor neuron along with involvement of the lateral spinal thalamic tract.
Okay.
Okay.
Okay. And what other cases could we get in terms of CNS of nervous system?
So you can get a hypotonic child like this, and then one of the other hypotonic children could be simple Down syndrome, Prader-Willi, or hypothyroidism. But hypothyroidism is more of a differential diagnosis. You will actually not get a hypothyroid child in your station because they are well managed. So generalized hypotonic child, young child, and then if it's an older child, it's more than likely to be a hemiplegia, ataxia, or
Ataxia can come.
or HMSN, hereditary motor sensory neuropathy. So these are more commonly in the older children age group, and then DMDs in the age group of around 8 to 15, 8 to 12 years old, or 8 to 15 years old.
Okay.
Okay, so
or like a proper spastic quadriplegia and a
Yeah.
wheelchair, CP, proper CP.
Yeah, complete full-fledged CP, either diplegic CP or a quadriplegic CP. There could be a component of hypertonia or hypotonia, both. There could also be abnormal movements, and then you have other kind of cases with abnormal movements like chorea or dystonia.
Chorea dystonia, mostly videos will be shown.
Yeah, chorea you more. But I've heard they had you can get actual patients with chorea.
These would be with a CP with basal ganglion lesions.
CP with upper motor neuron lesions, that you can have a bulbar palsy, you can have a spastic with contractures in the legs, in the limbs, and so yeah, these are the more important clinical signs. Bulbar palsy, if there's pooling of secretions, and you have
in King's College Hospital. Once there was a child from Africa who had this thing, kernicterus dystonic CP.
Okay, dystonic CP.
Abnormal. So CP can have wide range: hypotonia, hypertonia, and then abnormal movements like dystonia.
Okay.
Most likely it will be very straightforward. But we are trying to make you, or you say, assess the child in a full holistic approach. Okay, so that you answer in a holistic way, like focusing on nutrition, neurosurgical reference, and acutely what will you do. You will get an ultrasound done, and whether the child needs tapping, you will check for sun setting sign, look signs, or any hydrocephalus like that. So we want you to get full marks. That is why usually the exam will be very straightforward, but for your bad luck, sometimes it could be a very complicated case like this as well.
Yeah, I would say this is the most of the. I've put the extreme of the complicated case, but if you are prepared for this, you should be able to answer many other questions.
Okay, that's perfect.
Okay.
Yes.
In CP, always in CNS, always look for VP shunt. Then what do you say? A patch, hyoscine patch in the neck. Okay, neurocutaneous markers. Just put it in your mind so that when you go, you're fully prepared to look for everything. Yeah.
Okay. Yes.
Okay.
Yeah.
So I will end the meeting.
Thank you. That was really helpful.
Yeah, no problem. Okay. Bye.
It was a very good case. Yeah. Thank you.
Thank you.